Please welcome moderators, Drs. Mohammed Baida, John Cheek, and Andrew Putnam.
Thanks, everyone. Thanks for coming to this session. This is one that my co-moderators and I, John and Andrew, are very excited about. We're going to be talking about registries, which are houses of data, and artificial intelligence and how those things interplay and relate to one another. Our first speaker, we'll have a number of speakers today. Our first speaker, very happy to introduce, is Dr. Tony Asher, former president of the Congress of Neurological Surgeons, current president of the American Association of Neurological Surgeons. He is a neurosurgeon at Carolinas Neurological Institute and also heads the Neuroscience Center at Atrium Health, one of the largest health corporations in the United States. So, Dr. Asher.
Good morning, everyone. You're going to have a lot of really interesting speakers here today talking about some very specific issues related to registry use. I just want to provide a few framing comments, if I could, going back to when we first started looking at the use of registries for a variety of different purposes. So, origins of our national data programs really date back to about 2010, perhaps slightly earlier than that, but it's a good time frame to look at in terms of what we were considering. And there were a lot of forces that were making us think about this, but I really think they're appropriately grouped into two categories. One is the rise of value-based care. And we'll go back to that in a minute. But the other was concerns about prevailing methods of evidence generation, particularly in procedural specialties. We all know about the limitations of RCTs in particular, but aside from enrollment issues, aside from ethical issues related to procedural specialty use of RCTs, the bigger issues were that there were some questions as to whether or not the information being based mostly in large academic centers was generalizable to broader populations. And so there were real questions about how we could, as a community, start developing better medical evidence. Our conclusions at that time were, and this is from a paper that we wrote, I'll mention in a second, all physicians need to engage in scientific inquiry and quality improvement through the application and analysis of practice data. Now, that's a pretty lofty goal, but we use that as our frame, as our ultimate objective. Legacy data systems were inadequate to accomplish that objective, particularly information based in EMRs, and we thought that we required a novel and radically expanded methodology for clinical data science based on real-world clinical practice, again, just not academic centers. We published this paper in JNS in 2013. We defined this science of practice that visualized a day when all physicians or most physicians would pool data collectively. They would interpret that and they would use it to develop standards of care and apply it to continuous quality improvement. And as I said, evidence generation. The three elements of this were the habitual and systematic collection of data, inseparable from our clinical activity, the analysis of practice data to generate new knowledge, and the application of that knowledge to changes in healthcare. I won't go into this in great detail. I think that most people in this audience are familiar with the broad advantages and disadvantages of registries, but the main advantages of these vehicles are that data can be generalized to broad populations because we have broader inclusion criteria, if they're done correctly. The observed outcomes, therefore, may be more representative of what is achieved in real-world practice. Again, that issue is what sometimes limits the generalizability of information from RCTs. They're easily scaled. They tend to be cost-effective compared to other methods of generating evidence, and they're supported by multiple healthcare stakeholders as a path forward. Our early experience could be summarized as followed. We started with a spine focus. We thought that was appropriate. That's the majority of what neurosurgeons do. And in fact, the quality and value of spine care is being doubted by a number of stakeholders. We picked very aggressive objectives. Now, again, we're going back to 2010 when most clinical registries were based on 30-day observational outcomes, and out of the gate, we decided we were going to collect PROs and we were going to do it out to a minimum of 12 months and trying to achieve very high rates of follow-up. That was an incredibly high bar. It was so high a bar that going out of the gate, 5 major centers characterized what we were doing as human subjects research, and we literally had to go to the White House and see several of my friends here were involved in this interaction, Steve Glassman being among them, Dan Resnick, where we had to, through a very significant regulatory intervention, and Steve Ondra helped facilitate that, convince OHRP in particular that this was consistent with their regulations regarding continuous quality improvement. There was rapid adoption by Vanguard centers that were very motivated to do this and had the resources to collect this type of information. We subsequently scaled this broadly to all practice settings, which is very important with respect to our representatives issue. Academic centers, community centers, rural, urban, we really had a cross-section of surgery represented. And I'd like to think that we created a culture of data collection and analysis that did not exist previous to that. Reflections over the last 12 years are as follows. With respect to our future state predictions, we were half correct. There were stakeholder challenges to efficacy that really became predominant and really made us focus our data collection on addressing those things. And frankly, the value-based approaches didn't pan out the way that we thought. Now we're circling back to that. But value-based care didn't become as big a driver for this as we thought. And so the observational realities were these, and I think Steve is going to be talking to these in a little bit. The quality of patient data in most EMRs was very poor. We knew that was going to be the case, but that mandated a real manual method that became a little bit rate limiting. There was limited relevance of automated data collection if we were just automating the collection of data that wasn't helping us. EMR interoperability was a challenge. Local data environments had their own standards for data permissions. Diagnostic and procedural fidelity was a challenge. I think Steve is going to be talking to that in more detail. But it is sometimes, if we cannot define comparable cohorts, then the data lacks meaning. And there were analysis realities. As it turns out, our data was more reliable, and we'll get into this, I'm sure, in other lectures. If we were trying to determine what worked in general, it was less reliable if we were going to compare individual performance. And that meant that in terms of continuous quality improvement, comparing yourself to another surgeon in another practice became very difficult. And that was really one of our first goals. But there are pathways forward to this. So our outcomes, QAD and its evolution, became unprecedented scientific vehicles. And that was mostly, however, information that was analyzed in a number of sophisticated sites. A small subset of these Vanguard sites were able to use it for both academic purposes and continuous quality improvement and value-based care. But the majority of sites became part of a clinical and data quality culture, which was still, we thought, a very important national objective. They gained skills and experience with respect to quality data collection, but they were unable to use this effectively for benchmarking or quality improvement, and this is going to be a focus going forward. So the future, value care is coming. I'm going to tell you, working in a very large healthcare system, the third largest in the nation right now, incentives will start driving innovation and adoption of these techniques. There's absolutely no question about that. Our experience will help guide that path forward because we've made a lot of mistakes, but we've learned from those mistakes, and that can inform our care paradigms going forward. So in anticipation of this value paradigm, the largest systems I can tell you right now are adopting advanced approaches to high-quality data production, collection, analysis. Claims data is being added into that so we can really get to the value equation. Top of license standards for data entry. Again, Steve, I think we'll talk about this, but surgeons need to be entering surgical data, period. That's the only way that that's going to be accurately recorded. And finally, and this is what you're going to be talking about today, we're looking at technology trends. I think that AI will be most applicable in these areas, defining cohorts accurately, extracting accurate patient information. In other words, the information that we're going to be using for risk adjustment, and finally, accurately identifying observed outcomes. So I really think that if we're extracting information using natural language processing, there are a number of things that are skipping our attention right now that we'll be able to pull out through these methods, and those methods will be here before we know it. So I'm going to finish there, folks. Again, this was just a broad framing exercise, but hopefully this gives you some perspectives on where we started 14 years ago. And later today, I think you're going to see what the path to the future is. Thank you.